far, and I would like to first acknowledge funding from CHR. We're very thankful for the funding we received, and I would also want to thank deeply the collaborators that they have so far put a lot of work in, primarily Dr. Asma Ahmed, our postdoctoral fellow, who has done a great amount of work behind this presentation and behind this work as well as Prakesha and Eleanor, who have been great, very helpful in both the clinical aspect, but also the statistical components of what you're going to see today. So I'm going to give you a quick introduction on the socioeconomic impact of preterm birth, or the impact of preterm birth, and the rationale for why we're doing what we're doing. I'm going to talk a little bit about the data sources and SDLE. Briefly, there was a previous talk by Statistics Canada on SDLE, and I'm going to refer to some aspects of SDLE that I think are of interest. I'm going to discuss methods and the process that we have followed and some tips for using SDLE, next steps and what we've learned so far. So I'm going to follow this path from inception to data analysis, but unfortunately, as Eyal mentioned, this work is ongoing, and today there's going to be exclusively about the inception, the data, and the methods in the analysis, as well as some extension discussion as opposed to results, because we are we're waiting for RDC access for the data. We are almost there, but unfortunately, the timelines did not work. So preterm birth is defined as delivery before 37 weeks of gestation, is the leading cause of neonatal morbidity and mortality in children under 5 years worldwide. So nearly 15 million infants are born preterm each year, and those account for almost a fifth of the deaths in children under 5 years of age. And one thing to note is that the adverse outcomes after preterm birth are inversely proportional to gestational age. In Canada, preterm birth affects approximately 8% of all live births, making it one of the most common adverse birth outcomes. And while survival rates after preterm birth have steadily improved in Canada and other developed countries over the last 4 decades, this has created preterm birth infants are still vulnerable to a range of chronic physical, developmental, and behavioral morbidity. And the fact that the threshold of viability in preterm birth has reduced to, or keeps being lower and lower, that creates, a cohort of kids that they survive with a low gestational age. So children born preterm often require greater healthcare resources or need special education and social services. In addition, costs are endured by families as they make lifestyle and work adjustments. Past work from our group has identified that the healthcare costs associated with the time children spent in the NICU is on average around $20,000, with gestational age playing an important role on resource use. The non-healthcare cost of preterm birth is also significant, with a 2005 study in the US placing the annual societal cost of preterm birth at approximately $26 billion, which translates to about $51,000 per infant born preterm back in 2005. Surveys in the US of parents of children born preterm have identified an association of preterm birth with unpaid time off work, increased financial debt, about 2 years after an ICU discharge. However, most of the literature has focused on healthcare costs, with little emphasis on what happens over the long term with regards to the socioeconomic challenges of preterm birth on the individuals, or the burden from the parents' perspective. So if we look at the individuals, despite the increasing number of these preterm birth born children who survive, the amount of research is limited. And in addition to that, some of these studies have been faced with methodological limitations. Studies have reported conflicting findings on the direction of the effect. Studies have longitudinally tracked hospital-based cohorts of preterm birth survivors, and thus were vulnerable to selection bias due to the loss of participants during follow-up. There were small sample sizes in most of these studies and has limited their statistical having enough statistical power to detect small to moderate associations or create stratified effects across the spectrum of preterm birth. Several researchers have selected their study population based on birth weight rather than gestational age, and that possibly resulted in an overrepresentation of small for gestational age infants born at later gestations and did not consider the whole spectrum of preterm birth. And the few population-based studies that examined the educational and economic outcomes after preterm birth were limited to Scandinavian countries where more inclusive educational and economic opportunities might be available than other countries, and making these results somewhat less generalizable to different settings. So the family, as mentioned, also endures high out-of-pocket expenditure and for health and educational services after preterm birth. And previous research on the family cost of caring for children with excessive healthcare needs, such as those with complex chronic conditions, have shown a substantial negative impact on maternal labor force participation, overall productivity losses, and reduced income. Parents can also endure significant direct medical costs for services not covered by public health insurance, such as physiotherapy. Previous studies faced similar limitations as with those following the affected individuals, with, for example, small sample sizes and limited follow-up. So we felt that these gaps in the existing knowledge necessitate the further research to quantify the socioeconomic implications of preterm birth, both from the side of the individual, but also the mother, so as to have a more comprehensive understanding of the effect. So we proposed conducting a national cohort study, pan-Canadian, to examine the effect of preterm birth on individual and maternal labor market participation, income, and educational attainment outcomes. So these are the three aims of the study that we are conducting. We want to evaluate and quantify the attributable long-term impact of being born preterm on education attainment, labor market participation, and employment income. We want to do that for the individual, but also we want to evaluate and quantify the attributable impact for the maternal impact on labor market participation and maternal and family income. And we want to quantify the independent effect of risk factors, confounders, and mediators on the outcomes of individuals, mothers, and families following preterm birth. And by maternal here, we refer to the birthing parent. And throughout the presentation. So we have we relied in the social linkage data environment to construct a linked data set that we would follow, that we will analyze. And a bit of background, one of the collaborators, Jason Paul, has conducted a similar linkage, or has utilized a similar linkage to understand the economic consequences of cancer in adolescents and young adults. And that was, I think, the motivation behind what we've done. So I'm also very thankful to be part of that project that also sparkled this collaboration. And that is a message going forward, I guess, that, take this presentation perhaps and motivate yourselves in applying it in a different field. But a little bit about the social linkage data environment. It's a platform for safe record linkage of health, tax, education, and much more data. You can find on the link that I've placed on the bottom information about all the available data that can be linked through the social linkage data environment. And this is being constantly updated or frequently updated. So, the linked data can become accessible through the RDC, the Research Data Center, and the SPLE itself is a part of Statistics Canada and promotes the innovative use of existing administrative and survey data to address important research questions and inform socioeconomic policy through record linkage. So we thought that the environment looked perfect for what we wanted to do. So I'm also going to give you a little bit of the process so that you are aware of what needs to happen so that you can get to the data. So we have to fill in a proposal form when we are accessing the data, or to access the data, and need to provide a detailed description of data linkages, provide the database names, the variable names. I want to shout out to Statistics Canada for the great support that they provided on understanding data availability, existing linkages, what is in the pipeline from Statistics Canada or other researchers. This communication early on has been critical and very, very useful. And then Stats Canada will provide a letter of support and a budget estimate if new linkages are requested, and a note that it's important to start early on inclusion or on the process if you're thinking of including this letter in the grant submission. From our experience, at least, it was very useful that we started quite early. And so this is a timeline that we have faced so far. Obviously, this is one example. Others might have different pathways, but we have started, let's say, the agreement at month 0, and the agreement was signed. There's linkages that they need to be approved, and then the extraction that happens quite early, and then data extraction. It took us about a year until data are extracted, validated, and documentation is complete from Stats Canada. We don't see any data until that point, and then about a year later, the data were transferred to the RDC. And as I mentioned, we are anticipating data access within the next month or two, hopefully. So the whole process has taken to us about 14 months. So that is something to consider also when if you're thinking of using the data, that it's there is obviously a time lag between the signatures and data access. That can be significant. So some of the data sources these are the data sources that we used, and these data sources include vital statistics data. We used vital statistics birth and vital statistics death registries for defining preterm birth and also capturing some of the demographics of the individuals, that their age at birth, their sex at birth, their age, and parity also for the moms, for the maternal information as well. We used vital statistics death for mortality information. The STLE allows linkage with the tax data, tax family files. So we have extracted income after age 18 for the aim of understanding the long-term impact on the individuals, and maternal and family income for the impact on mothers and family. And the SDLE also provides access to post-secondary information system database, which allows us to understand whether there was post-secondary enrollment for individuals 18 years after birth. Other sources that we've used is the employment insurance status vector, so we can understand whether the birthing parent or mothers received parental leave or decided to go for parental leave. We linked to the 2006 census so that we can achieve to extract information on maternal education, race, ethnicity, and country of birth. And we linked to DAD, which gave us information on child health and maternal morbidity. And we linked to NACERS, the National Ambulatory Care Reporting System, to understand ED resource utilization or ED visits for child and mom. So you can see that the information you can extract from SDLE you can link information from both the health space and the socioeconomic space, education. It's quite rich and complete, and spans quite a large window of time. So I'm going to start with aim 1, the understanding the attributable long-term impact on the child. So what we planned to do is to create a matched cohort study with children that they were born between 1983 and 1996. They were singleton, live births. We only focused on the first baby, and we excluded patients or individuals with congenital malformations. One thing that perhaps it wasn't clear so far is that we have linked mom and baby. We have a linked mom and baby data set, so we can extract information for both maternal and child information at birth. We have that allows us for a follow-up period of minimum of 21 and maximum of 34 years for the individuals that they are born preterm. And using that information, we will develop two matched cohorts, a preterm cohort and a term cohort. And the matching it will allow us to understand the attributable component of on the outcomes. We have proposed to do exact matching on birth year, province or postal code, depending on the data, and sex. And we will use propensity score to match on other variables that include family income, maternal age, employment status, education, family structure at birth. The outcomes we're going to be focusing on are employment income, which would be the annual employment income in 2007 Canadian dollars, going forward after age 18. So for every year after 18 that we have follow-up, we will measure the annual employment income. And similarly, for labor market participation, we will measure whether an individual after their age of 18 claimed any taxable employment income, whether they were enrolled or have completed a public post-secondary program, and we will track deaths as competing events. So you can see a schematic of the data sets that are being used for each aim and the time frame and the outcomes of each time frame. And this is the child. So you can see that we will follow essentially infants after their 18 year of age with a minimum follow-up of 21 years and a maximum of 34. So the first aim, we will use a method called multi-state modeling, which allows us essentially to model transitions of individuals across different states. We will break their time until end of follow-up or death into different states where we can understand how individuals transition from one state to the other, what is the intensity of transition, and how does preterm birth affect this intensity of transition. And this is essentially a multi-state model is a generalization of a univariate survival analysis. You can think of it as a multivariate survival analysis method that can address competing risk challenges, because individuals that they would exist in one state would not be at risk of existing in another at the same time. So with regards to annual employment income, we will use generalized estimating equations so that we can account for the repeated measures and matched cohort structure of the data. And we will stratify our analysis across gestational age and calendar year, because they are both important factors that we think are the important factors across all the studied outcomes. So we will create 5-year bands for birth year and categories for gestational age that we will stratify on. So aim 2 focuses on maternal outcomes and the impact of preterm birth on maternal outcomes. We will again construct a matched cohort of mothers who gave birth between 2006 and 2012, singleton, live births, only the first baby, and we will again exclude congenital malformations. We have a shorter follow-up period because we're matching at 2006 census so that we can have additional information for education and race at baseline and family structure at baseline. So the follow-up period is shorter, between 5 and 11 years. And again, we will exact match on birth year, sex, and province or postal code. And we will propensity score match on family income, maternal age, employment status, education, family structure at birth, and maternal morbidity at birth. Because we have information on maternal morbidity through that, the DAD. We will focus on employment income, which is the annual employment income each year following childbirth. The adjusted family income, which is the sum of the total income for all members of the family, adjusted by family size. The labor market participation is going to be defined similarly as before, whether a mother claimed taxable employment income post-birth. Family leave is an outcome that needs to be captured because to understand whether a mother has claimed and for how long maternity-related employment insurance benefits, because this is a competing outcome to labor market participation. And again, mortality is going to be captured as an outcome as well. So these are the data sets that are being used for the purpose of AIM2, and you can see that the follow-up time is shorter, and that's partly because the linkage with census 2006. Another point worth noting is that we are also going to have a 2-year look-back window for both mother and child cohorts, so we can incorporate information at baseline. So, for example, the socioeconomic, family income and maternal income at birth, cumulatively within the last 2 years, comorbidity within the last 2 years, and so on. So we'll have a look back window before. You see a much more complex structure here on the multi-state model that we are proposing to follow mothers after birth. So mothers can be alive postpartum, and they can go on a family leave, or they can go back to full or part-time employment, or they can be unemployed. And we want to differentiate between them, and then follow them until their second birth, if any, and then third birth if observed. So again, we will compartmentalize essentially their time across the different states and try to understand through non-parametric and parametric approaches what is the attributable impact of preterm birth on the transitions between these different states over time. Just a note here that this is method that has been developed, has been becoming more popular over the last few years, given the computational improvements. And we have used that method in the past to estimate similar effects of interventions in COPD and ALL in acute lymphoblastic leukemia, pediatric acute lymphoblastic leukemia. So for the rest of the outcomes, annual and family income, again, we're going to use some generalized estimating equation to, again, account for repeated measures and match cohort structure, and we will again stratify on gestational age and birth year. So moving to AIM3, which is to quantify the independent effect of risk factors, confounders, and mediators on the outcomes of individuals, mothers, and families following a preterm birth. We are essentially we will try to understand the relation between risk factors like unemployment and lower educational attainment as they relate to outcomes, while at the same time being risk factors for experiencing the event itself. So preterm birth, there's the high probability of experiencing preterm birth on people that they are long-term unemployed or with a lower educational attainment, but also these are risk factors for experiencing worse outcomes in the long term for the children and for the maternal outcomes as well. So we will try to disentangle essentially this relation. And the other aspect that we need to capture is the fact that events that occur after preterm birth can mediate the impact on outcomes. For example, lower educational attainment that happens after birth can be a mediator for outcomes, or can the effect of preterm birth can be mediated through lower educational attainment, or there could be a direct preterm birth effect on financial outcomes, so income, for example. So we want to understand the effect of risk factors such as maternal age, education, income, rurality or deprivation, and maternal comorbidities, and the child's sex on the outcomes, but we also would like to disentangle the effect of mediators such as child comorbidities, subsequent births, or maternal labor market participation on the outcomes over time. And these mediators can also, the challenge is that these mediators are going to be likely to change over time, so they're going to be time-dependent mediators. So we will rely on the cohort that we have constructed in aims 1 and 2. So the cohorts, the maths cohorts, the two sets of maths cohorts that were constructed in aims 1 and 2 are going to be the ones that are going to be used for the purpose of aim 3. And again, we will rely on a G regression for employment income so that we can again account for repeated measures and the correlation structure of multiple repeated measures for income for both children and parents and maternal income. And we will incorporate in that regression baseline risk factors and confounders to understand the effect of employment income. With regards to labor market participation and educational attainment, we will construct multivariable multi-state models where confounders and mediators will incorporate it as time-dependent covariates. Now, this will allow us to understand perhaps the direct and indirect effects of mediators or the effect of baseline risk factors on the outcomes. But in order for us to create a causal effect of these of some of these confounders, we will rely on a method that is called microsimulation or agent-based simulation, which essentially is a construction of a synthetic population that needs to that will be essentially transitioning through a series of states with specific intensities of experiencing events, and through that we will be able to understand the causal effect of some of these confounders or mediators on the outcome, hopefully. So I will give you a little bit of a walkthrough on our microsimulation process that we are hoping to construct. It has been recently shown that this approach of microsimulation or agent-based simulation is mathematically equivalent to parametric G formula or G computation for causal interpretation. This method, we have used it in the past to understand disease trajectories and to understand the epidemiology of disease. The microsimulation has been used frequently for that purpose. Has been used for population average effects of interventions. Some of the work we've done before in COPD relied on that. And it has been used in the literature to disentangle the kind of path-specific effects of exposures and interventions. And that's what we are hoping to achieve here. So we will generate a hypothetical synthetic cohort that is going to be based on the original data set that we will receive from Stats Canada, but it's going to be a synthetic version of it, but will include baseline covariates and with the correlation structure that is observed in the original data, and we will simulate outcomes under pre-specified interventions or under counterfactual scenarios. So how that works really, we can think of our preterm birth cohort sitting here, and what we do is we construct a version of that. We could construct a synthetic version of that cohort where the important characteristic or the covariate of interest is set to as a given value. Given that the value of the characteristics, or even better, we subset the specific synthetic cohort to include only the characteristic of interest. Then we utilize our multi-state models, our multivariable multi-state models, with condition on the fact that the whole cohort has this unique characteristic of interest set to 0 in this case. You can think of it as smoking, yes or no. So these are the non-smokers. And we utilize our multi-state model to estimate the transition intensity between different states, conditional on the characteristics of the preterm birth on this synthetic cohort. We pass this synthetic cohort of 1,000, 10,000, 100,000 individuals, depending on what is needed and our computational ability, through the state transition model, or this state, through the state transition model. So everyone starts alive and less than 19 years old, and then they have a risk of transitioning across the different states. And over time, individuals from that cohort will eventually transition to, wherever they are going to be landing say 10 years after the beginning of follow-up. And we do that, and we store the results, and we go back and we construct essentially the same data set. Now the same data set we have constructed, the synthetic data set, we flip their status from 0 to 1, or from non-smoker to smoker, or we say, what if we had a modifiable factor that we could modify the value to a given new value? And now, given that new value, we utilize again our multi-state models to rerun essentially the same exact cohort through the state transition diagram, but obviously with different probabilities of transitioning across the different states, because we have changed the modifiable factor in our data set. So people are gonna transition through different pathways, perhaps, or fewer people are going to transition through some pathways, and more people are going to transition through others. And at the end of the follow-up that we specify, so say 10 years of follow-up, what we do is we measure the outcome of interest for both the control and the intervention, or the two essentially counterfactual cohorts that we created. And using that output, we can construct relative estimates of the effect of the modifiable factor that can be interpreted as causal if some important assumptions, of course, hold. So that approach has been kind of well documented in the literature in the last few years, and we have utilized in the past for the purpose of estimation in other disease areas. However, there are anticipated challenges with the methods that we've proposed. We expect missing data in the data once we receive them. We expect that for some, although we have a very large population of births within this window of time, very preterm birth, information on very preterm birth or under 26, 24 weeks is likely to be limited for some years, and especially historically. It can be that the data set is non-representative given that the improvements in outcomes have, preterm birth outcomes have existed over the last years. So individuals born in the 80s and the 90s might not be reflective of what happens on an individual that's born today. And we are aware of it, very well aware of it. And there's some incomplete data on immigration. We don't know necessarily for those people that they move in Canada. We don't know very well what was their gestational age at birth, and we don't have information for some of the baseline characteristics. So that is a problematic for us. There's always the possibility of residual confounding after matching. We're expecting to have computational challenges, especially with M3. We have utilized the high-performance computer in the past year, but at RDC we don't have the ability to do so. And we are aware that there's a possibility for violations of some of the assumptions that are being made especially in M3 with regards to mediation, and we are going to be testing what possible, or trying to understand conceptually if that is the case. So a bit on our next steps, we hope we're going to finalize data access within the next month, and that allows us to actually access and analyze the data finally. We have, I should have mentioned, and we have a great collaborator who is who is a representative from the patient side and the stakeholder, because she acts as kind of with both hats, and we want to strengthen the engagement with her. Fabiana she's great, and I think we can learn much more by strengthening further the engagement. And a past talk on that from Chess has been great for us to learn more. Then we will have obviously the steps of dissemination and knowledge translation. And as I kind of mentioned before, these kind of projects are great for food for thought for extensions based on the same data set. So we have an interest. We're going to be partnering with social epidemiologists to understand the effect of socioeconomic factors on outcomes, and understand the intergenerational mobility on this cohort. The other thing that I need to mention is that this data set and it's on the process side, this data set has been constructed and uploaded on the RDC. And there's a period where a veto period, but after that, the data set is available for researchers to use. So that also is something that you want to keep in mind. This, the funding that we have used to create the cohort, I think, serves as an investment for future research from both us, but also anyone from the community who is willing to work with the data. So what we've learned so far, we've learned that SDLE is a powerful data source for child health research. That's what we think. The linkages are great for understanding long-term effects of interventions or disease. It's important to engage early with Statistics Canada and collaborators with SDLE so that you can understand better what is available and use their kind of experience from day one, essentially, of your project. The timelines can be lengthy, and this is usual when it comes to linked data. You need to plan ahead and use time efficiently. So, for example, we have focused more on methods development. We created a data set, a simple data set, so we can play with it, or we use dummy data from the public, sort of the open public space environment, so that we can work on the methods while we're waiting for the data. And as I mentioned before, I think it's a great investment for future research because the data set becomes available after some time to the community for further research. So that is these are some references for you if you want to look through them. And thank you very much again for inviting and for sticking around for the talk. And I'm happy to answer questions.
Thank you, Petros. That's fantastic and super clear. I think we're going to open the floor for questions. Just a quick, Petros, before I take the first question from Eleanor, there was in the chat box. Can you just remind Daphne Cohn from Statistics Canada joined, was just asking what data sets you linked in this project. Can you just repeat that again before we take the first question?
Sure. I have the list. You can see the list here. The vital statistics, birth and death, DAD, NACRS, T1 family file, pieces, the EISV, the employment income information, and the census.
Thanks, Petros. I think the first question is Eleanor's and then Teresa's. Go ahead, Eleanor.
Thanks, and thanks, Petros. This is a really cool data linkage and project. And what I'm wondering in terms of computation time is that I'm wondering whether you can accomplish the same as you accomplished with the microsimulation by actually doing the integrals. Because like my understanding is basically the microsimulation is avoiding having to do some integrals. And I think it would be messy, but I think once it's worked out once, it kind of solves the problem in perpetuity.
Yeah, that's a great point. And I think the challenge is the answer is yes. There are people in the literature that they discuss the exact same problem. Like the people that they move to agent-based models are those that they try to avoid the integral. I belong to one of those. The challenge you might have is with weird time-dependent effects that, especially if you have, I guess you have to assume a parametric. If you assume a parametric form to that, I don't know if the integrals are you thinking of a closed form solution or of a numeric optimization on an integral? Because
yeah, either, depending on the parametric form. Like if it's an exponential, it's super easy. But yeah, like to your point. I mean, the other thing is if you do have time-dependent covariates and you're using a maximum likelihood solution to fit the model, you just have to watch out for endogeneity. It could like really mess things up.
Yeah. Okay, I think we need to talk more about that outside of this talk to understand better where or you can maybe elaborate on where you would expect the endogeneity to occur in that setting.
Well, anytime you have a time-dependent covariate, which can be both affected by the outcome and then later affect the outcome. If you're
Yeah.
maximizing a likelihood, that's going to be
Yeah.
a problem.
Okay, I understand what you mean. Yeah.
But it might just, like, if you take out the time-dependent covariates, I think it's easier to evaluate the integrals. But I take your point, if they're in there, it's very tricky.
Yeah.
Thanks.
Thank you.
Teresa.
Yes, thank you. Great talk, Petros. Your approach is awesome, as always. I don't have any methodological questions for you. So my questions are more kind of logistic question about working with StatCan on the data linkage. So I think that's great. That's a great option for people like myself who work on admin data. There's now an option to do those kind of linkage through StatCan. The data that you link, that you show, that you link to, DAD and NACRS, they're kind of a little outdated, right? You use data up to 2017, 2018, where we know actually through ICES, we now have that kind of admin data through to 2021. So you're kind of behind. So any information that, StatCan may provide more up-to-date health admin data linkage? Especially, we are all now kind of interested in health services use during COVID. So 2018 is kind of old.
Yeah, no, you're right. You're right, and also thanks for the feedback. I suspect, and I think I'm not the right person to answer that. I think someone from Statistics Canada would be a better person to answer, but I think that there is a limit of human resource capacity, I guess, on how quickly people can update the data in SDLE. But I also, again, from the experience of accessing the data, going through the process of accessing the data, I don't know if it would be that straightforward as in ICES to say that, okay, I have this cohort, now we have this extra 2 years of data. Can you add the extra 2 years of data on our existing cohort? I think there's a bit more process, but the answer about how quickly the data will be updated, I hope that it's quick enough, but I don't have the answer myself. I don't know if someone from Stats Canada who is in the call could maybe provide some input, but it would be, as I mentioned also in the talk, like the fact that we have older data also affects our interpretation going forward of the findings, and things are changing so quickly so it would be really nice to have more up-to-date data, but yeah, we worked with what we had at the time. Maybe now, yeah, I think that's going to stop there.
And maybe just to follow up on that, Petros, you did mention that the data that you linked and that you have could be potentially made available to other people who want to use it for research. That sounds great. And what about if I want to contribute another data set to be linked with yours, like air pollution and environmental factors? Could I bring that to yours to be linked?
So that's a great question. The answer is generally yes. So you can bring external data to SDLE. There's going to have to go through a different process than accessing the data directly. So it's not going to be, it's going to be an additional linkage. So it has to go through the same channel that we went through of approvals and evaluation and validation and so on. But you can bring your own data in, yes. And what I don't know, and again, I think that we would need more clarity on that, is who owns the data once they're in Stats Canada. So I assume that you are also willing to provide the data to other researchers once you link, that they can conduct their research, after a veto period. So I don't know how these data privacy considerations happen. If you have a randomized clinical trial and you want to link it to bring it in, does it mean that everyone else has access to that randomized clinical trial? This I don't know the answer, but generally you can bring your own data in.
Sounds good. Thank you, Petros.
You're welcome.
So we have a lineup of 3 people. Next, Daphne Cohen.
Hi, thank you. Thank you for that really, really excellent presentation. And just because we work at StatCan doesn't mean we always know everything that's going on at StatCan.
Sorry.
So this is really great. I'm so excited about this data set and about your work and the microsimulation. So it's really, really awesome. And I have to congratulate you on sticking through the process. I don't know how it was for you, but we often hear that it's really challenging and time consuming and the approval process. So thank you. This is great. I'm really excited. So I think I've asked you other times if you're aware of the work that's being done in the Health Analysis Division on the birth cohorts, but they've only done vital stats to census linkages. But, you know, there should be some exchange of information, maybe sharing of resources or something. So that's one thing. Yeah.
May I ask, is it Tracy?
Yeah.
Yeah, we had a conversation early on when the project was being developed about that's where we discussed who is doing what, because we saw that C is the one that does most of the work, or a lot of work on that domain. So I think C is aware, but that was back in 2019. So I think it's up to us to reach out again and have re-engage in that conversation with her.
Yeah, and it would be great to engage Leanne Finley's group, who she's part of our kind of steering committee for these seminars, because her team is specifically focused on child health, and there may be some opportunities there. So just putting that out there. I wanted to maybe answer some of the questions that have come up. Okay, so just about the recency of data. So one thing is just remember, like, it takes a while to process the information. For example, vital stats comes in from all the provinces. It has to get cleaned. So, you know, we don't always have the information as soon as we would like, but seeing how you've done the hard work in terms of the approvals. Hopefully in your letter, you put something in there about having updates, because the updates to add like future cycles of the information is really straightforward, not so expensive, and of course really valuable to do. Like looking at this for like pre-post COVID, like, is golden. So that's awesome. So yeah, I encourage that. And the other item about bringing in external data, so it's extremely sensitive. You have to have specific approvals for it. There's a big issue about data ownership, and just something to realize is once data comes into Statistics Canada, it's considered StatCan data in terms of confidentiality, privacy, and all that, but it doesn't necessarily have to all be put in the RDC for everyone to have access, although often that's, you know, what we'd like. So that is also something that could be pursued. But I mean, I think I don't know if it's Teresa who asked the question, but I think you know StatCan, and we just don't do things in the most simple way, but we do have to ensure that certain conditions are met. But it's absolutely a possibility, and we've done that with other cohorts. We've brought them in and we've linked them to StatCan data. But again, it has to be all approved in the very formal process. So I'll stop with that.
Thank you so much. And thanks for the tips about reaching out. Yeah, I will do right after.
Maybe I'll pass on to the next question is, or Daphne, put your hand back up. Do you want to?
No, I did.
Okay, John Snellgrove, welcome.
Thanks very much. This was a really interesting talk. I'm an obstetrician. I work at Mount Sinai, and I have a big interest in severe maternal morbidity. And I wanted to ask you about, I think I missed kind of the description about this, but I think you mentioned something about matching based on the presence or absence of severe maternal morbidity. And I guess my two questions, the first being, with matching, will you be able to model the effect of severe maternal morbidity, particularly for your second aim with maternal and family, subsequent maternal and family income and education? And secondly, a lot of the events leading up to maternal morbidity are also the same events leading up to preterm birth. So I'm wondering whether you can truly match on severe maternal morbidity if you're looking for a preterm birth cohort and a term birth cohort, and just wanted to hear your thoughts on that.
Yeah, that is these concerns are what led us to AIM3, where I mean we anticipate that some of the obviously like some of the maternal morbidity is going to be the cause of preterm birth and also affect outcomes beyond preterm birth for mom and baby. So we hope that some of that we can address on AIM. So we kind of recognize these limitations on AIM2, but the point about matching on morbidity and whether what you will see is going to truly be the effect of preterm birth or the effect of maternal morbidity is we know that this is a challenge. We hope that like the AIM3 is going to answer the question that is going to be created in AIM2. So I guess what I'm thinking right now, and I'm cautious, is we refer to that as the attributable effect of preterm birth. But what you're saying is essentially that this could be very well not attributable to preterm birth, but it could be attributable to a condition that caused preterm birth, which is exactly, again, going back to looping to AIM3, is what we are hoping to try to disentangle in our third aim, where we're trying to understand the effect of confounders and mediators on the outcome.
Thank you. That was it's a very elegant analysis, so I look forward to seeing the results.
Thank you.
Next question, Doug Campbell. Hi, Doug.
Hi, Al. Hi, guys. Thanks so much. Petros, I don't think we've met, but I'm a neonatologist. I work at St. Mike's in the NICU there. And so we work with a lot of families, obviously, who are disadvantaged or new immigrants to Canada, and have all these questions that you've sort of laid out. So I think this is amazing work. I just see myself and my colleagues in the NICU community as downstream users of this fabulous work that you're doing. So really look forward to the results of this, specific, and I'm particularly interested in, things like trauma and mental health and immigration on ultimate outcomes. So really, really excited. Thanks so much for sharing this. Look forward to seeing the results.
Thank you very much. I just want to again mention that I'm a health economist, so we started with a very socioeconomic approach to that problem. But please remember that the data is going to be available, and any future students or people that they might be, they have the capacity, either financially or from a time perspective, to work with the data. I think it's like, if you put your questions down, I think there's going to be the data is going to be available for a possible student in the future to analyze. So we're not going to be able to do everything, but I think it's, the data is there and other questions can be answered. But and we're happy to provide also, we are very open source generally in the way we work. So all the work we're going to do is going to be posted, like our code and everything is going to be posted, so other people can use it in the future as well for that purpose.
So on that note, thank you, Petros, for a fantastic talk. Again, lots of really key learnings, I think, about the patience that is necessary to embark on these sorts of projects, but the incredible wealth of data, the opportunities to link data sources that many of us have not been working with in the past, and also the development of some innovative methods that address some of the strengths and limitations of using some of the StatCan's resources for longitudinal data analysis. So on that note, I just, on behalf of the Leong Center, and I want to thank everyone for joining today. And please come back on April 29th for the next session in the series, which again will be on educational data specifically. So thanks, everybody. Have a wonderful weekend.
Thank you for inviting.